Awesome. One more question. Are you using ultrasound to help guide resuscitation in like preload? So, seeing if your bolus actually gets better filling of the heart, if the kid is either hypovolemic or septic and vasodilated.
I would say, we will definitely be using it to sort of define the sort of pre-fluid appearance of those structures. So like if I see a kid whose heart is beating very vigorously, has great sort of functional appearance, and an IVC that looks when I think about the IVC, and I didn't mention this during the talk, I often think about it in the sense of like, can it accept fluid as opposed to is fluid resuscitation going to help the patient? In the sense that like we don't necessarily know if we give fluid in some patients whether it's going to definitively improve their heart rate or definitively improve their blood pressure. But if you look at the IVC in the context of a resuscitated patient, you can often tell, am I going to make someone a lot worse by doing this? So you look at their heart and it's squeezing very well. You look at their IVC and there's quite a bit of variability. It may or may not be super collapsed. And so, and then as you go along, you're giving fluid and you're looking again at those things and seeing if they're changing in some concerning fashion. Am I now seeing B-lines? Am I now seeing an IVC that looks really, dilated and full? And sort of using those sort of serial examinations to kind of guide things. So I wouldn't say that, I could guess in a strong way, and I think the evidence would bear this out too, that you can't really get from your initial examination a good sense of whether fluid resuscitation is going to be effective, and that your other clinical kind of things that you're looking at the bedside are going to be part of that whole package. But you definitely can use it to sort of help gauge whether you're doing something horrendously wrong, I think. Does that sort of answer that question, hopefully?
Yeah, I think it does some. Some of our adult hospitals have mentioned children with poor preload, and that they were using ultrasound to kind of give boluses and notice the preload improve.
Yeah, and I mean, I think there's two things to think about there. I think guys who work in the adult world are definitely looking at factors in the sort of called a POCUS examination that are a bit beyond what we typically do in kids, like more quantitative measures, which really I don't have a huge kind of basis of knowledge to speak to, but they will look at some more cardiac determinations that will show that increased preload. But I think, again, they're also probably using the IVC as well to guide some of that as well, to sort of say, does this IVC look like it's underfilled, which there is, the literature is not great for IVC on its own to guide fluid resuscitation. There's been a lot of sort of controversy around that, particularly depending on whether patients are intubated or not, and a lot of the research is done within the context of ventilated ICU patients, where you have the best kind of gold standards for comparison. So I'm not quite sure what they would be using to define poor preload. I suspect it might be some more advanced cardiac skills that I didn't sort of get to. But yeah, I mean, I think that idea of looking at the ability of the heart and the IVC to tolerate fluid is sort of, for us, what I sort of use as a way of determining is that going to kind of be something that might be effective in this patient, and then using the clinical guidance thereafter after giving the fluid to see what it actually did.